from NCVH 2024, and this is the 25th anniversary. I'm really privileged to be with Dr. Khusrow Niazi to talk about a very important topic for primary podiatry as well as cardiology. Dr. Niazi, thanks for being with us.
It's my pleasure. I'm been a part of this conference for many years, and I'm honored what Dr. Walker has done for all the physicians in educating them.
Absolutely. So, as we spoke offline, is about foot ulcer. And there's a different type of foot ulcers into diabetic foot ulcer or vascular or no vascular disease. Right. Can you tell us about overview of the issue and then how to work it out?
So many times, in the clinic, a patient will come and you find that they have a wound on their foot, and that's been going on for weeks or months, And primary care physicians, usually when they see them, either they send them to a wound care center or a podiatrist or vascular surgeon. But I want to encourage the primary care physician that they can identify the underlying etiology and the pathophysiology in their office if they just follow simple algorithms. So many times, just identifying the patient who is at high risk of atherosclerosis. If somebody comes in who has had coronary bypass surgery or carotid interventions, they are more than likely to have blockages also in the lower extremities. So they should be highly suspicious. If somebody is a smoker, they should be suspicious. If somebody is a diabetic. And this has been shown by old studies, partner study that was done in 2001, published in JAMA, where they took patients above the age of 50 who were either smokers or diabetics, or people above the age of 65, anybody above 65, and they did ABIs, and they found that a significant number of patients have peripheral arterial disease not diagnosed by their primary care physicians. So I think it's very important for primary care physicians and all of us to do the ankle brachial index, which is such a simple test, and it has no complications. I mean, we tend to do EKGs. I think the yield of an ABI is more than just doing a 12-lead electrocardiogram on population coming in.
Absolutely. And is this something readily available in the clinic, and how the primary care can do it?
The ankle brachial index is it's easily available in the clinic. They can teach even the MAs who can do this test. And not only it will help in the diagnosis, but it will also is reimbursable test. So if a patient you diagnose PAD and you have done an ABI, you can bill for that test. Now, I'm not saying you should be doing this test for billing purposes. I'm just saying that if you diagnose the disease and you have done this test, just like an EKG, you get paid $12, for a treadmill you get paid. Similarly, you get paid for ABI if you diagnose. And if you diagnose, doesn't mean you're trying to generate volume for intervention. It's basically the diagnosis of peripheral arterial disease will then reduce their risk of future coronary events, cerebral, by treating their cholesterol, by getting them to exercise, weight loss,
so
smoking.
And managing them.
Exactly.
You know there's a problem.
That's right. Yeah.
Any other tools that you can use, or screening or awareness tools we should use for our patient beside the testing?
Yeah. So I tell people the best tool that I diagnose peripheral arterial disease is by asking their family. I ask them, have they seen their father or mother are walking slowly? Can they not keep up with them when they're walking in the malls or outside? Or have they observed that they have become more sedentary? To me, that is the strongest clue that those patients must have an ABI done. Yes, you can do the physical exam and it will show, hair loss and the skin will be thin, atrophic, not much swelling. But on top of that, they should also consider venous insufficiency, which is far more common than peripheral arterial disease and really gets ignored because people think it's a benign disease. It is benign, but it causes a lot of symptoms in the patients.
Absolutely.
So physicians should have a very low threshold of either getting an ABI or a venous Doppler if their physical exam and the history. To me, the history of peripheral arterial disease, walking slowly, and to me, the history if their legs are swollen or get tired at the end of the day or severe cramps or pigmentation of the skin, that's a classic sign that they should rule out chronic venous insufficiency.
Absolutely. Well, that was a very wonderful overview of evaluation and management and diagnosis, simple test as well as questionnaire for patient coming to the clinic with venous or arterial ulcer. Thank you so much, Dr. Niazi, for joining us.
Thank you very much.
Watch these videos and others on the YouTube channel. This is Chadi Alraies from NCVH 2024 in New Orleans. Dr. Niazi, thanks again.
Thank you.